Good morning, everyone. So, welcome to our grand round this morning. Some of you may know that we have these grand rounds about 3 or 4 a year that's open to the external health professionals. So this is the first of the series for 2014. So I understand that quite a lot of you are psychologists, so I'm really pleased to see therapists and psychologists coming here, because over the years, the last 3-4 years, we've been trying to engage health professionals, focusing a lot on GPs and psychiatrists. But as you know, we are a therapeutic program, and we constantly like to kind of engage therapists and psychologists, because one of our policies, many of you may not know, is that every client that gets admitted to South Pacific Private is referred to a therapist or a psychologist after discharge. That's a policy. So we are a psychotherapeutic program, and so I'm really pleased to see that many of you are psychologists, and I understand that some of you have some special interest in chronic pain, so feel free to contribute. The topic today is on chronic pain and addiction, and we particularly chose this topic because it's very trendy. There's a lot of discussion about the increased use of opiate abuse, analgesic medication abuse, and also over the last 2 years, we've definitely seen an increase in the number of clients coming in with prescription drug abuse. There's no question about it, and many of them are related to opiates, and some of them with pain, and some of them are not necessarily related to pain. And as a result of that, we explore some of these clients and look at their previous management. And many of these clients have had extensive treatment for their chronic pain, mainly symptomatic treatment, pharmacological treatment, attended many pain centers, but they are not getting better. And when we look at it, and as we will discuss later, it's a very complex with multiple contributing factors to the pain. And we were not surprised, but many of them have similar sort of psychological issues to people with general addiction without pain. So it looks like the pain is a symptom of quite a lot of underlying issues, including trauma, childhood trauma, abuse, and other kind of psychological factors. And in fact, we ended up treating many of these clients with the kind of approach that we use, with treating the underlying trauma issues, using the recovery kind of approach, and also family therapy as well. And I think this is something that may be lacking in terms of the services that we have over in Australia. But there's been a lot of movements in US looking at the recovery approach, like what you will use for addiction in terms of treatment of chronic pain. And this is what we're very excited about, is because we can use this recovery approach in treating both chronic pain and addiction at the same time. And we'll talk about that as we go along. So I'll just go through the brief introduction on this topic. And then we'll have 2 very interesting cases for discussion. Steve will present the cases. Steve is our program director. And we've chosen these cases particularly for grand rounds and with audience like you, because they are complex and challenging. So I look forward to the discussion. Okay, I'll give you some statistics. I think many of you are aware of some of these issues. So there's been a lot of studies looking at pain, and this is a study that was done in 2009. I think they found that about 5 to 10% of the population have severe persistent pain. And in the 2002 studies, it reported that up to 20% of the population suffer from pain, and that the pain is strongly associated with markers of social disadvantage. So when we look at pain, obviously there are this acute and chronic pain. So acute pain is something like it ends when the body heals and the need for pain is gone. And it's adaptive, as we know. I mean, if you break your bones, it's painful, you're not supposed to walk. It's a kind of protective thing, and you need to do something about it. It's a warning sign, and it's an adaptive thing. So, but when the condition improves, then the need for the pain is gone. And in chronic pain, it never ends. It seems like it annoys, it detracts from life, irritates, frustrates, and it doesn't go away. So when we look at this physiology of pain, so when something is triggered, the nociceptive receptors in the peripheral, like in the bones or the skin, will send a message to the nervous system, to the brain. And at the brain level, the thalamus starts to process the pain, but then it becomes quite complex. In a simple pain, the thalamus will process the pain. You withdraw from the source of the pain or do something about it, and it gets better. But it's more complex because it looks like there are other receptors from the limbic system, the hypothalamus, the amygdala, the hippocampus. So these are emotional centers that actually contribute to the thalamus in the processing of the pain. And then, of course, you get this autonomic nervous system with the adrenaline and the noradrenergic sympathetic system as well. So the idea that in terms of even the biology of pain, it's not just as simple as something triggering the pain, going to the brain, but then it's a lot more complex because other parts of the brain gets involved in this system. So chronic pain, some of these kind of information about the chronic pain. Firstly, all pain is real, despite there no longer being an acute physical reason for its presence. I think it's quite it's not very therapeutic when you see a client coming to you with chronic back pain and the limping, and you know that the source of pain is not there anymore because it's been about 10 years since they have the chronic pain, but they're still limping and look quite crippled, disabled. And sometimes you start to think, come on, let's get on with that. It's not real. But if you have that approach, it's not therapeutic, and in fact, it makes the condition worse. And also, ignoring the pain can be quite dangerous. They will present a case where a patient has chronic pain, opiate analgesic abuse, and actually end up with a real serious bowel problem that was ignored because the doctor thought it was just another case of presentation of the chronic pain. So that's a reason why I think we should always evaluate a pain case freshly and not be nihilistic about the approach. So it's a pain that kind of generally lasts for more than 6 months, and very often, almost 100% associated with some kind of emotional issues. Depression, anxiety, anger, irritability, poor concentration, memory problems, physical and work incapacity, and low self-esteem. So chronic pain, so as pain becomes chronic, the sensory component of the pain becomes less important. The emotional and behavioral components tend to take on more importance. And, there are so many studies that have done looking at these emotional and behavioral problems, including history of deprivation, emotional deprivation, neglect, abandonment. There are significant contributing factors to chronic pain, even with attachment theory, with insecure attachment. And there have been quite a lot of studies looking at this chronic lower back pain, which is the most common kind of chronic pain. And they look at work-related lower back pain, and the two main contributing factors to the chronic pain is job dissatisfaction and poor performance at work. So these are kind of psychosocial factors. And also it depends on the meaning of the pain to the client. The client tend to blame other people or be preoccupied with a sense of hopelessness. It's kind of a locus of control that would determine whether the pain becomes chronic or whether they get better with the pain. So when we look at management, the expert consensus and it's the growing body of research says that the best practice in pain management requires coordinated interdisciplinary assessment and management involving at minimum, this is not just minimum, physical, psychological, and environmental risk factors in each patient. and that the chronic pain should be selected according to particular characteristics, not a one-size-fits-all. I mean, this is common sense, but particularly with chronic pain because of the complexity of the individual history. So there's also evidence to suggest that if we approach it through a multi-dimensional pain management approach, that people do get better and that they can return to work and improve their level of functioning. So it's not as gloomy as we think with people with chronic pain. So we tend to see people who have chronic pain as clinicians when they are not getting a lot better. And sometimes it can be quite discouraging, but there are a lot of people who do get better. But I think you have to be careful when you say, how you define getting better. So when with chronic pain, the definition is not complete pain relief. It's how you live with the pain. And that is the outcome that you need to look at, not the complete relief of pain. So sometimes, GPs, when the client presents to GPs, they like to kind of give them enough analgesic medication to completely eradicate the pain. That sometimes is not necessarily a good goal for someone with chronic pain. So much of the supply of the prescription opiates in Australia and also in the US is in the context of people with CNMP, means chronic non-malignant pain. The reason why they say it's non-malignant is that there's to differentiate between that and people with cancer, with terminal cancer. Now, in that situation, as part of palliative care, then we are not that worried and a little bit more generous, I suppose, in terms of prescription of analgesic medication. But in chronic non-malignant pain, there's an estimate that 20% of the population suffers from it, and this is likely to increase with aging population. And as I mentioned earlier, and this is supported by a lot of research data to indicate that there's a lot of warning research information saying that there's been a significant increase in the prescription of analgesic medication and the abuse of analgesic medication. So there's a 44 increase in oral morphine use between 1990 and 2006, and a fourfold increase in oxycodone between 1990 and 2003. There's also an increased reports of death associated with prescription opiate overdoses. This is reported to be the second most common abused drugs, which is, I mean, I'm not sure whether it's surprising to some of you, but it's only after cannabis, and it's ahead of cocaine, heroin, and methamphetamine. And the reason for the death is, as you know, in opiates, if you take a chronic use of opiates, you develop certain tolerance to the opiates. And it's like heroin. And then if you have a period of abstinence, you lose their tolerance, and taking that same level of opiates can stop the person from breathing. So it's a very kind of dangerous drugs to use, to abuse if they are not aware of the issues of tolerance. Some interesting stats from the Centers for Disease Control and Prevention in US. This is 2011 figures. 15,000 people die every year from overdose of prescription analgesic medication in US. 15,000. And 1 in 20 will use the analgesic medication for non-medical reasons. And this is a kind of an interesting figure. There's enough prescription analgesic medication prescribed in 2010 to medicate every American 24 hours a day for at least a month. There's a lot of analgesic medication. So there are kind of different ways where people will present with opiates abuse. Firstly, there are people who started off being prescribed medication for real pain. They suffer from some kind of pain. And after a while, they start to have some drug-seeking behavior. They need more because of the pain, and they start to use beyond the prescribed dosage. These are not that many in terms of the overall proportion of people who present with opiate and analgesic medication. Although we have seen a few people who started off innocently being prescribed analgesic medication and then became quite comfortable and became addicted to it. Another group of clients would be people who use other drugs as well. They abuse alcohol, heroin, and amphetamine, but they've just happened to kind of found that prescription medication is also another drug that they can abuse. So it's a polysubstance abuse population, and we see a lot of that. So quite often they come in with amphetamine use, alcohol use, and then when you take a history, they have also been using prescription analgesic medication. The other challenging situation is how do you manage a person with real chronic pain and has become dependent on an analgesic medication? And we've got this case later to discuss, because these people do need some kind of pain relief, but they become addicted to the medication. So it's tricky. How much do you kind of take them off it? What do you do with them, particularly if they have significant pain? So ideally, all people who commence on opiates for chronic pain should have been assessed by a multidisciplinary pain service. And this is not happening, of course, because GP do prescribe analgesic medication. And I think, I know it is controversial, but I mean, that's ideally, I think they should be assessed properly before they are prescribed this analgesic medication. Another group of people that we see, people of heroin abuse, they come in for their heroin abuse, or they started to abuse their buprenorphine as a maintenance treatment. And they can't come off this medication. But maybe this quite significant number of these people do have underlying pain that's never been addressed. So the people now, they've been told, well, you've got to come off your heroin, or you've got to keep on taking your buprenorphine because you can never come off it and maintain them for 2 years. But not really appreciating that some of these clients may have some kind of chronic pain, and they're actually taking this to relieve their pain. So of course they're not going to be wanting to give up their buprenorphine if that's the case. Another interesting thing is topical at the moment with some of our public figures, is the presence of opiate abuse in the context of major depression or psychiatric disorders. So depression, dysthymia, generalized anxiety disorders, panic disorders are associated with the use of prescribed opiates in the general population. Because it does, some of these opiates they are mood altering. It does help with the mood, the anxiety, and therefore they end up actually abusing the prescribed opiates. In addition, sometimes, quite often, with benzodiazepine as well. So chronic pain is quite disabling. It affects their ability to enjoy, do exercise, do activities like housework, social activities, sexual dysfunction. So there is a kind of psychosocial reactive depression or reactive anxiety as a result of chronic pain. So I'll just talk briefly about the medication, just straight quickly. Firstly, there are people who use non-opiates medication for pain, anticonvulsants, Lyrica, Tegretol, antidepressants, the tricyclics, NSAID like Nurofen and Celebrex and muscle relaxants. They are non-addictive, but they're quite often used excessively in people with chronic pain. But the more worrying are the addictive medications. So amphetamines, stimulant medication, is also abused because it does help the chronic pain to some extent. We don't see that many barbiturates, but it's still used. Benzodiazepines a lot, Valium, because Valium helps in the muscular spasm, and of course it makes them relax and all that, so they become quite addictive to benzodiazepines. Hypnotics, and of course the opiates are very much abused. The buprenorphine, codeine, we've seen people coming in with 120 tablets a day of codeine-related analgesic medication. And they don't realize that because they're just like addiction to heroin because they're opiate-based. So if you come off codeine at 120 tablets, you go through significant withdrawal symptoms, like as if you're coming out of heroin detox. But the public, they don't realize that. They just think that you can get it from the chemist, it's legal. I mean, just in terms of the actual medication, and they do a lot of doctor shopping. And fentanyl is quite often abused. It's a very powerful analgesic medication. We had a case last year, someone came in 20 times the level of prescribed fentanyl. It was a big guy, was just walking around, and he started taking it because he was very anxious. And the reason why he got access to it was because his wife was suffering from cancer, breast cancer, and they were giving the wife the fentanyl. And he took it and felt really fantastic and ended up taking 20 times the level. He came in and wanted to come off it just, he didn't require any medication and all that, but he went through a very serious withdrawal for about 4 weeks. But I've seen him now, only over 12 months, he's free of that fentanyl. He still doesn't really understand why he got addicted to fentanyl, because it's a biological addiction, it's not just psychological. So opiates are very common. So how do we know that they are, how do we know they're addicted to it? Just common kind of things to look for: excessive use, asking for more, tolerance. They're not the same dosage, no longer have the same tolerance. They go doctor shopping, aggression, irritability, hoarding, saving drugs, inappropriate use. Example, they will use it whenever they feel stressed or anxious. And then sometimes they start using other illicit drugs. And of course, complained by family and work employers. So there are alternative options for treating pain without necessarily using analgesic medication. Just some of the social factors, addressing lifestyle issues, diet, sleep management, exercise, psychological techniques, relaxation, CBT, counseling, and physiotherapy, hydrotherapy, mindfulness, biofeedback, and those kind of psychosocial approach needs to be considered and implemented in patients, in clients with chronic pain. So as I mentioned earlier, after that last year, we were quite fascinated by this, the chronic pain in terms of the similarity with addiction. And we started to look at recovery approach to chronic pain. So we have the recovery approach, the 12-step approach to addiction. And interestingly, there are some work done in US on this issue. So in the recovery approach, we look at individual management. So it's not just seeing the doctors, but it's kind of developing a particular program for the clients. And it's abstinence-based. So if we can, we try not to use any medication because that really can drive the addiction. And we try and get them to get involved in 12 steps model in meetings and to learn to accept and coexist with the pain. We empower the clients rather than making them feel that they are patients and victims of the pain, and the solution-oriented kind of approach. So in other words, we look at the physical, psychological, social, and spiritual aspects of the treatment. And the aim is not to control or eliminate the pain, but it's to help the client to deal with the suffering and achieve relief from the suffering rather than relief from the pain. And we've been talking to some of the pain treatment centers at Prince of Wales Hospital and Royal North Shore Hospital, and they're very interested to try and explore this particular approach to pain. And there is a guy called Mel Paul, M-E-L-P-O-L. He's written a book here called A Day Without Pain. It's very easy to read. It's actually for clients. And he has been doing quite a lot of work on this pain recovery approach at the Las Vegas Recovery Center. And we're actually approaching him and trying to learn something from with that kind of approach, hoping that we will develop some kind of programs using our existing recovery approach to try and deal with people with pain, and particularly people with chronic pain and addiction. So that's the plan for, well, that's one of the plan for 2014 for us this year. So if any of you have ideas or you'd like to kind of contribute or discuss, feel free to contact me or Jackie, our public relation manager. So the other thing that we do a lot over here, as many of you know, is family therapy. And not surprisingly, I think we know that the pain affects the whole system, including family, because they become withdrawn, the alienation, they lose their identity in the pain, they're treated like invalids, they've been misunderstood, dependency issues, secondary gain, and sometimes the compassion that the family give could be actually reinforcing the sense of helplessness. It could be counterproductive, you know, being kind of over a matched kind of relationship. So I think there are a lot of family issues, and some of which could be actually perpetuating the chronic pain. And also we need to help the family to deal with the pain and understand the chronic nature of the condition.